Dr. Thron.
Thank you, everybody. Welcome to Dementia Possibilities. I certainly am honored to be part of this. I think, Jutta says we're going to do the serious part and the humorous part. No, the fun part. And I think I get to do the serious part. So bear with me and I'll try and make it not too serious, even while hopefully educational. I know that you have lots of choices and I'm delighted that you've chosen this possibility of being with us today. So as the conference plans evolved, because, as Jutta said, we had a lot of time for things to evolve. The idea was that we would bring humor into our talks. And for me, that brings up a lot of my fears. I honestly, bringing humor into topics that are serious is a very, very valuable way to help people integrate information. And I absolutely value that. But when it comes to the idea of telling a joke, I get terrified. So, I'd rather talk in front of a huge group of people than try and tell a joke. Once, probably my most embarrassing moment ever in my life, or one of them, was trying to tell a joke that I had heard probably 50 times in the same night that I tried to tell it. And yeah, it was a disaster, needless to say. In 40 years since then, my friends have not let me forget how bad it was. So, that may be a genetic thing, that I just don't have that kind of capacity to tell a joke. Certainly it might be like not being able to sing on key, which is also something that I fundamentally cannot do. So here's what I promise you: no jokes and no singing from me today. So on the other hand, my wife's family can tell jokes and tell you funny stories from their lives for days. They've been through a lot of hard times and they use humor in the most amazing way to see them through their challenges. And I admire that. In fact, I hope to learn that. I hope by association at least, and maybe even ultimately by actually sitting down and saying, okay, how do I learn the timing and things like that, that I too will get there. I guess they got the genes for it, I'm not sure. But they also got the genes from her mother's side for Alzheimer's dementia. My mother-in-law lived with us for a short time and then also near us here in Santa Fe, even though she came from Oklahoma, for the last 4 years of her life as she was living with dementia. And so she taught me many things about life, humor, and dementia, some of which I'm going to share with you today. My mother-in-law's name was Jane, and Jane had a fascination for shiny, sparkly, and colorful things. And I enjoyed indulging her in those things. I would buy her fun, wonderful things that I found, like these odd-shaped marbles that were really colorful. But I have come to appreciate more and more over time that they served a therapeutic purpose. And so, wow, I realize I'm leaning into the screen to try and get closer to you all. So in a moment, I'm going to actually ask you to do an exercise that's based on her love of shiny things. But first, I'm going to give you another disclaimer. Not only do I not tell jokes and I don't sing, but I am not a specialist in neurology, gerontology, even dementia. I am a family doctor by training, which means that I'm a generalist, both by training and by nature. And as a result, I have to just tell you up front that when it comes to the details of the pathophysiology of the brain, I may fail you. I just don't know that level of detail. So I'm going to focus on the broader picture and hope that serves your needs. I am a specialist in hospice care, as I've been doing that over the last 12 plus years now. And later on in the conference, I'll be speaking more about hospice and dementia. But I have been working with people with dementia for all the years of my practice now, almost 25 years. So today I've accepted the task of giving this brief overview of dementia. And what I really hope from it is that it gives us the same, that we all are working then from the basic same premises. We have a basic understanding of where things are with dementia, and that we can talk from that place. And I'm sure that, well, in fact, I know that many of my colleagues who are speaking today are much more experts than I am on dementia, but hopefully this will nonetheless give us this baseline amount of information to work with. So yes, and I hope that by doing that, it really allows us then to explore the many different aspects of the challenges, but also the creativities and possibilities of living with dementia and loving or caring for somebody who is living with dementia. Broadly then, dementia is defined as a family of diseases that have a common progressive decline of brain function that interferes with an individual's capacity to carry out their daily lives. That last bit is sort of the key portion. And not only that it's a progressive decline, but that it interferes with the capacity to manage daily functioning. Because it's in that detail. Oh, there you go. You put me on spotlight. It is in that detail that we really make the distinction between, yeah, then I don't have to feel so close because now it's just me there, right? So it allows me to back up a little. The distinction of, if we are trying to distinguish between somebody who has mild cognitive impairment, or maybe the normal changes that happen with aging, and the actual impaired functioning that we classify as a dementia. So before I go on into any more detail, I'd like to ask you to do this exercise with me. This is to honor my mother-in-law, Jane, who again loved bling and shiny things. So if you have anything that you have close by you, since you're in your own homes, it's different than being in a conference room or anything like that. So look around you. You might be that you have a beautiful thing on the wall, or you have a glass of water in front of you that is shiny, or you have some bling yourself or some sparkles that you could take. I have borrowed this from my friend whose house I'm sitting in. This so suits my mother-in-law, Jane, that I just am delighted to use this. So here's the thing. I ask you, if you don't have something blingy like that, that if you even have a glass of water, or you are looking out a window and you can see the dappling of light through the, or a water bottle, thank you, the dappling of light through the leaves, or any of those kinds of things. That's what I'm going to ask you to put in front of you or have with you right now. Hopefully you can all find something. If you don't have any sparkle in your life, gosh, I'm sorry. I encourage you to do something about that. So if you have this thing in front of you, oh, and if you don't have any of those things, you can also just pick something, a rich, beautiful color that speaks to you, the leaves in front of you. It really can be anything that is not just the piece of paper or the screen in front of you. So I hope you can find something. So I ask you, take a few moments, take some deep breaths, do a quick check-in of how are you feeling, and then let your attention be drawn to your object. I guess I could let you all look at that one, but no, I'll have you everybody do their own. Continue your regular breathing, breathing in and breathing out. Balancing, if you can, the in-breath and the out-breath. Allow yourself to look at this shiny object or other object. Move it around a little bit. See if the light changes the colors, the reflections. Is there movement in it? Allow yourself to be drawn into the dance and the depth of what is going on in front of you. Let your thoughts wander freely over the surface of your shiny thing. Move it, touch it, Let your thoughts go. Take a few more deep breaths and bring your attention to your breath and then to your screen and back to this conference. And then take a moment to see, are you feeling any differently than you were before this exercise? I find that sometimes even a short moment of refocusing can really allow us a different perspective. When Jane, my mother-in-law, when she was in her moderate stages of dementia, she had this bag, well, she had many blingy things and shiny things, but she had a bag full of these things that sometimes when she would be dwelling in her anxiety or agitation or in her past losses or trauma, she would pull out this bag and she would sit down on the floor and she would put out all her bling in front of her. And she would look at it and she would appreciate it and she would touch it and play it and organize it and talk about the pieces. And I could literally watch her calm herself down and find some peace and then be able to have a happier countenance, be more open to a conversation. It was really so brilliant to see how something like that, something so simple, could be used in that way. Many years ago, I had this opportunity that I wish I could share with all of you. It was a puppet show about dementia. And they were these incredibly handmade puppets that were child size. And the puppeteers were the caregivers of the people who had dementia. And maybe somebody, one of you will recognize this and be able to give me more information about who that was or what it was. Sometimes the puppeteers were also playing people with dementia. It was a multimedia experience where there was poetry and writing from folks with dementia. And they were, there was sometimes profound insight and sometimes lightning and piercing clarity and thoughtful observations. And sometimes the lights flickered or went dark and static became so loud that it drowned out everything else. And I've thought about that so many times since then, because somehow for me, it gave me some insight about what that might be like to be inside the brain of somebody living with dementia. Not because everybody has that experience, that particular one, but the idea that the brain is maybe like a malfunctioning machine at that time where there's a faulty wire or radio static as you drive certain place and then all of a sudden the static overcomes the station you were listening to. That's the kind of experience that any one of us has had. And so if we think about it like that, sometimes that might give us an explanation or an idea about what might be going on for somebody with dementia. And Jane, in her internal wisdom, had been able to find a way to keep that static and the chaos at bay for herself. So I hope that gives you a new appreciation for bling. So back to an overview of dementia. Again, dementia is an umbrella term that includes many, many diseases that cause a slow progressive decline in cognitive and functional ability. Really a better term would be for that family of diseases is neurocognitive disorders. And we wouldn't get so hung up in dementias because as happens quite often, I hear it all the time, even with people where I think that they really probably ought to know, is that, and it is an important distinction about Alzheimer's. Alzheimer's disease is how we've referred to it for many years, but really I think we do it a big disservice by calling it Alzheimer's disease instead of Alzheimer's dementia, right? As a result, I think there's still a lot of confusion out there and people talk about Alzheimer's and dementia as though they are two different things. But really dementia is the umbrella and Alzheimer's is the largest part of what lies under that umbrella. So Alzheimer's disease, Alzheimer's dementia is the diagnosis that makes up the largest part of all dementias. About 60 to 80% of all dementias fall into that category. Amongst the other kinds of dementias that are very common are Parkinson's related dementias, frontotemporal dementia, vascular dementia, and then many, many other ones. And a common one that we tend to not talk about or overlook is and probably therefore more common than we realize, is mixed dementia, meaning that somebody may have aspects of Alzheimer's, but they may also have vascular disease and have had mini strokes or things like that that are also contributory. So in all neurocognitive disorders, there's a progressive death of brain cells. And the pattern of where that starts and where it progresses to is probably the clinically most important factor. So, because that's what tells us about the brain's, what's going to be affected. Knowing the anatomy of the brain, which I admittedly don't know in great detail, knowing the anatomy of the brain and knowing what things are being affected allows us, and understanding the function of that part of the brain then allows us to understand what pieces of functional capacity are going to be lost, and how we might expect the progression of a disease process to unfold. The best studied of the dementias is certainly Alzheimer's. A lot of money and a lot of research has gone into the study of it. And a lot of the progression of the disease has been well established, and there's a FAST scale that we use, that's the functional assessment scale, to help us understand how the stages of dementia are. And I'll talk about that a little bit more after, or later, excuse me, not after. So understanding the anatomy and the pathophysiology of the brain, and understanding the details of that can be very helpful if we're trying to understand where in the process of those changes or those disorders are things happening, because that way we would understand where maybe we can intervene into that course of the disease process. But from a functional place, from understanding dementia and the way that, is about ourselves, our colleagues, our loved ones, the people we're caring for, more important is knowing sort of where things are happening. And I think the easiest form of dementia, or the easiest way to understand that maybe, is when we think about a stroke, because a stroke is a very specific area of the brain that gets affected. A stroke happens when there's a lack of oxygen to a particular area of the brain. That can be due to a blockage of an artery or because of a bleed. If there's a lack of oxygen that's only for a very short time, you might have something like a TIA, or a transient ischemic attack, which is defined by the fact that all symptoms resolve within 24 hours. But if the blockage lasts longer and there are cells that are affected in that area, and then that ultimately die in that specific area, then we can see the functional impact of that very specifically, as most people have had that experience of meeting somebody with a stroke. And you can tell it's, they lose the use of one arm, or the whole side of their body, or their speech, or their ability to swallow. It's very functionally specific, which is not as easily seen when we look at the more global forms that cause dementia. If somebody had a stroke and had multiple strokes, maybe even small strokes where they are affecting things that you can barely tell, but ultimately over time that might lead to vascular dementia. Another example of the way that a brain can be affected, and this is my friend Cliff, actually, whose house I am in right now. He was diagnosed with a rare form of dementia. It's called primary progressive aphasia. Aphasia is the inability to speak. And I would describe this, when I would try and help my son to understand what was going on with our friend, as the disease is basically stealing his words. So it affected his words as the primary place where it caused the disability there. But the interesting thing that I realized from him was that if you take away people's words, a few at a time, you start to affect, as it did for him, his ability to speak, of course. So initially he was able to find words to work around the words that he couldn't access. But as it progressed, it began to affect his work. And slowly it affected his social world. and then his access to all his learned intelligence, if you like. But he did maintain his beautiful warmth and his smile and his bear hugs till near the very, very end. So that was the good news of that, the bad news of that. So the different disease processes, again, account for where the damage is going to be done, and therefore what the functional defects are going to be. And they can really affect any part of the brain, so that we can see deficits that happen in memory, of course, very clear one that we know well, judgment, spatial awareness, motor skills, motor functioning, executive functioning, word finding, speech access, pretty much any function of the brain that you could name. We can identify that things can affect that portion of the brain and therefore cause problems as a result. So again, the details of, say, tau tangles and amyloid proteins and things like that, the specifics of how that damage is happening are very important in order to be able to understand where we might intervene for medicines for the future, for maybe even gene therapy, to be able to help change the course of the disease. One of the newer drugs, the aducanumab, which is a monoclonal antibody that's engineered to be able to stick to the amyloid plaques before they can actually cause the damage that happens in Alzheimer's, maybe the kind of thing we're looking at. So to think about the differential diagnosis, if you like, that's medical speak for, all the different things that can possibly be happening in the brain that can look like dementia. When you first go, if somebody goes to their doctor and says, doctor, I'm really worried that I have dementia, the doctor will, or nurse practitioner, provider of all kinds, right, will ask you many, many questions, want to do a whole slew of workup, and it's okay. And before we actually confirm any kind of diagnosis like that. The kinds of things that we need to look for are blood work, brain imaging, psychiatric, neurologic evaluations that can help us to differentiate between all the different possibilities of what may be going on. And to maybe distinguish between, is this something that has come on slowly, or is this something that has happened acutely? So, because the most important thing is to, this is my friends have come in, the most important thing to understand is that not all changes in our brain function are due to dementia, right? Very important. Again, not all dysfunction of the brain is due to dementia. One of the common other forms is delirium. So when we're thinking about the broader aspect, so when somebody is, when a doctor is trying to evaluate for what's going on, we can think of it in other ways, break it down into reversible versus not reversible forms of dysfunction. We can break it down into acute versus chronic problems of the brain. So when you have cognitive impairment, that could be, things like confusion, hallucinations, changes in social involvement, memory problems, inability to walk a straight line, right? Many things like that. So delirium is an acutely disturbed state of mind, which is generally speaking reversible. So it's very, very important that we make sure that we understand which things are reversible and that we take care of those so that we can understand what might be underlying there if there's something else going on as well. So there's a very long list of possibilities of what kinds of things can cause delirium. And so many so that the doctors use a mnemonic to help them, and it's called deliriums. So the mnemonic says the D stands, for example, for drugs, and then under all of that is medicines, toxins, heavy metals, can be a whole variety of things like that. Some of those are reversible and some are not. For example, the lead poisoning that's happened in, say, Flint, Michigan with their water supplies, things like that, right? Some of that may not ultimately be reversible, but many of those things, and many of those things are actually things that we might even seek out, right? On a day-to-day basis, a glass of wine, for example, or some sleep aids to help us sleep at night. Those are things that we use on a regular basis, knowing that they will affect our brain in a certain way. But any number of those things can also cause adverse effects in the brain. The E stands for environmental issues. And one of the things that we commonly understand about that is, for example, when you've had multiple nights of not very good sleep, you may not think as clearly, you may not have access to your words as clearly, you know, a whole variety of things that you would recognize in that way, but that could look like or could feel like you were starting to have real memory problems or memory issues in that way. L stands for low oxygen. So if somebody has developed hypoxemia, low oxygen for some reason, they've gotten a worsening of their disease process, their COPD or their heart failure, and they're having low oxygen, for example, that might contribute to them not thinking clearly, not acting in a way that we expect. Infections, the I stands for infections, and that goes for so many things, very simple things from urinary tract infections, with many of you know, can affect, especially in the elderly and folks with dementia, their thinking and their ability, their hallucinations, many things can be affected by that. So even simple things, but certainly fever or sepsis or pneumonias can all do that. Here's another one, simple thing that I think we often overlook, especially in folks living with dementia in the later stages, is urinary retention or constipation. That can also give us an appearance of worsening dementia, acutely worsening dementia. Of course, things like stroke, tumors, trauma to the brain, so direct impact to the brain itself, those kinds of things, that's the intracranial I. Underhydration, so dehydration can also be one of the things that can cause symptoms that look like acute changes. And then some of the things that we also don't think about that blood work can often help us to rule out are things like thyroid disease. Somebody who has an undertreated thyroid problem can look like they have a dementia. They can have their brain functioning so slowed that it can really appear that way. And that is a very reversible phenomenon. Sleep disturbances, again, that's the last one, that's the S. I did include also, I don't know if the handouts are easily available or not, but I did include a handout which compares the differences between delirium, dementia, and depression. Depression is such a big piece because it can really mimic all the other things. Sometimes it's an acute onset, mostly not. Mostly it's a slower onset, but it can complicate almost everything else. And certainly in these COVID times, even more so. So it's always something that we need to be aware of and address if at all possible, because as often as not, if we can call that a reversible process. So all this is by way of saying this is why it's so important to do a full assessment before we make any assumptions about dementias. Neurocognitive evaluations are very detailed in their trying to assess the what portion of the brain is being affected. The other reason to do that level of detail is also because there are implications in terms of medical management, in terms of even after we've ruled out the reversible causes, genetic information. Is it a Huntington's disease that's causing the dementia? Is this something that the rest of the family needs to know about? Are there ways in which we can help them understand or manage differently as a result of different diagnoses or processes? The non-medical management, which my colleagues on this conference will be doing a lot of addressing. How do we structure the environment around people to support them so that they have their best possible life, even living with dementia? So as you all know, I don't think even to date, even not today in the front headlines, there wasn't anything about any new cure for the multitudes of different dementias. But we do know that there are some medicines and new ones on the horizon that are able to slow the progression of the diseases. And a vast amount of research that is moving us forward with the hopes that soon we will have more to offer, particularly things like gene replacement therapy, in which a virus would carry a new version of a genetically faulty gene into the system. And the idea would be that the body would then be able to use that and reverse some portion of process that might have happened. I'm going to talk a little bit from there about stages of dementia. But before I do that, I want to ask you this question, because Dr. Tony Camp, who many of you know, one of our Santa Fe geriatric psychiatrists, likes to ask this question of all of us. And so I relay it on to you. If you are not already somebody living with dementia, ask yourself, how will you be when you have dementia? What will your form of dementia look like? It's an interesting exercise. I imagine myself, who really probably swear next to never, to be the kind that will just be blurting out swear words all the time. That's me, I'm just saying. So prepare yourselves. So the Alzheimer's, so FAST score, the functional assessment scale, breaks down the stages of Alzheimer's dementia into 7 stages. I'm just checking time. I'm doing fine for time, right, Ken? Okay. From totally normal, fully able to function in their daily lives, to a slowly declining progression of unable to function at all and fully dependent on other people to manage their activities of daily living. It's a scale that has been well tested for Alzheimer's disease. It has not been validated for other forms of dementia. So even though we often use it sort of indiscriminately, if you like, to describe stages for other forms of dementia, but in reality, it is made and validated for Alzheimer's dementia. So we find that other dementias may not follow those exact stages. You may see, especially for people who have more of the primary motor disorders like Parkinson's disease, that their functional capacity in terms of ambulating goes down first. Or people with multiple sclerosis who may later develop dementia also, or ALS, may have physical functional decline well before they have cognitive functional decline. And so, I think it's just important to remember that just because we have this cool scale that's validated doesn't mean it will necessarily describe what's going to happen in every case of dementia. So I think that I'm going to be able to leave quite a bit of time for questions. So if you have things that you have interest in, asking me, please fire those away at chat, and then Ken will, I think, help me to facilitate those.
Yeah, happy to do so. So
Okay.
there are already a few
Wait.
questions. Go
I'm
ahead.
not quite there yet.
Gotcha.
Sorry about that, Ken. I want to share one more story from my experiences with Jane before I sort of wrap this up. So Jane, there are so many stories. And again, I tell you, I'm not the best storyteller, but this one is so classic. So one day Jane calls her daughter and she says, "Jamie, I've lost my marbles." And Jamie says, "Uh-huh." And she says, "I've lost my marbles and I think someone has stolen them." "Okay, have you looked around the apartment?" "I know somebody has stolen them and I think it's Karin. She stole them. Will you ask her to give me back my marbles, please?" There you go. We did find her glass marbles, but we did not, unfortunately, manage to gather the rest of her marbles. Thank you very much. Yeah, open for questions.
I think you are a good storyteller. Let's see here. So yeah, we have a few questions here. So sorry, I'm just scrolling up so I
That's
make
okay,
sure.
and I can see them now too. So I can answer the one for, do others see first that there's a decline, or does the person experiencing dementia first see that? That is very variable, very variable. Some people are so able to work around their deficits that the people around them can't tell for a long time until they really get into detail or depth about it. And sometimes they're so good at doing that that they don't recognize that they have a deficit there. So it can really go either way. Some forms of dementia are much more obvious, some are less so, both internally and externally.
Lucy asked, I think she meant Alzheimer's dementia. So is body pain a part of Alzheimer's dementia?
Aha. Generally speaking, not. Yeah, Alzheimer's dementia does not have pain associated with it the vast majority of time. I can't picture a time when it specifically has that as part of the disease process. Doesn't mean that there isn't pain associated with people living with Alzheimer's disease, dementia, because they may well have other things going on as well.
Melissa asked if you could go over that list from the acronym deliriums one more.
So the deliriums, you're right, if you put out DELI, and you go through them that way, the D stands for drugs, and it includes then, here, let me pull it back up again. Medicines, toxins, the things we take in or the things that we're exposed to. That could even be carbon monoxide, that could be heavy metals. E stands for environmental issues. And this is, I'm giving you the very brief issue, but let's say sleep deprivation could fit into that. Sleep-wake cycles can fit into that. If you have, daylight all the time, that can affect how your thinking is, or you have nighttime all the time, that can be affected, for example. L stands for low oxygen or other things. That's just one of the things, can be also high PCO2, so the carbon dioxide. I is for infection, and that covers all the infections, the viral infections, the bacterial infections, the results of infections, fevers, all of that. The R stood for retention of urine and stool. The I is for intracranial abnormalities, so seizures, strokes, tumors, trauma. U stood for underhydration, but can also be undernutrition. And M is for metabolic issues. That can be the electrolytes are off, glucose can be off, endocrine issues, thyroid. This is also where the hepatic encephalopathy, or the changes in the brain that happen with liver cirrhosis and liver issues, kidney issues, can also affect the brain and functioning. And S stood for sleep disturbances.
Awesome, thank you. Then Sally asked, she said that she's read a little bit about microdoses of psilocybin and even LSD having been used to gently reconnect and wake up the brain. What do you know about that?
It's such a fascinating area, right? How we're beginning to look at the way that these drugs can open up the brain, right? This is what we knew from the 60s and 70s about these kinds of medicines, is that they could open up things. And I honestly don't know enough to know how they're thinking about or using it for dementias. I have to admit, I'm fascinated to know more, look into that.
Lisa and Larry asked, can you discuss Alzheimer's resilience and why some people have it?
Yeah, I don't know the answer to that fully. I think that there are probably a whole lot of factors that play into that. What we know is that there are some forms of dementia that have a genetic association. Some people may have multiple genetic factors, and some people may not have as much, so that they may have a little bit more opportunity, resilience, if you like, in that sense, purely from a genetic place. I think that there are, for example, in my mother-in-law's case, she had underlying mental health issues also. Those are the kinds of things that make you likely to be less resilient. I think that's true if you have other illnesses in general, that you're less resilient. And also if your social situation or the structure of your life is not as supportive of you being able to maintain a good quality of life and consistency in your patterns, then that probably also affects how your resiliency is. So I suspect that it is multifactorial.
This might be more of a comment, but it's interesting. Sally says that she experiences delirium during pain from shingles. Um, is that common that pain, like extreme pain, would cause that?
I don't think it's common, but certainly it can drive us to, yeah, it can certainly look like a delirium. Yes. I
Mm.
haven't heard it quite like the light fixtures melting, which is very specific in your case, Sally, but I know that it can make us not think clearly, and a whole variety of things can happen with that, with acute pain. Yes.
And then it looks like the final question so far. Lucy says that her husband keeps saying that he can't walk, that he has major pain and tightness in his leg muscles and back, um, but does keep walking slowly with a cane. Could it be his brain is saying that he can't walk?
Hmm. I guess I don't know the answer to that. I'd have to have the, a little more detail in the pictures there. That's an interesting question, though. It's so challenging for us who are trying to help individuals interpret what's going on in their bodies and in their minds, to be open to the possibility that what they're saying is really how it is, without us jumping to conclusions about what we think or what we understand. And certainly this is a dilemma for doctors, right, who maybe even have a harder time listening to and staying open to the possibilities in that way. So I would say, if you know that there are physical issues going on, it may be that things like pain override the capacity, right? So that is definitely one aspect. Yeah, when I had severe osteoarthritis in both my knees, and it was amazing to me how the process of getting to the place where I couldn't walk very well came on so slowly that I would say to people, "Oh no, I'm not in pain. I don't need to do anything about it. I'm fine, fine, fine." But I realized that I parked closer to the door. I walked less. If it was going to be, a lot of stairs involved, I'd say, "No, thank you." And I just, after the fact, I had both my knees replaced, and after the fact, I can say, oh, I watched that process slowly take me to this place of so much restriction in my life. And so I wonder how much is, yes, it's our brain talking, but it's really also a response to our physical reality. So I don't have a good answer for you, but there's what I can say.
This is really interesting. This question kind of, I think it really gets to the heart of a lot of what we're focusing on for under the banner dementia possibilities. You spoke a little bit to the notion of living the best quality life that we can still live after a diagnosis. Susan asked, how do you understand some people with Alzheimer's becoming creative in new ways? For example, a person trained in art becoming an artist throughout their life, producing a wide variety of artistic expression, some impressively brilliant in ways that the person didn't seem capable of before.
Again, I suspect that there are a whole wide variety of reasons why this kind of thing can happen. Well, the first one that comes to mind is, in Alzheimer's, I think a lot of the inhibitions are gone. So maybe we just allow ourselves, right? It's not even an allowing in that sense. It's just the things that clamped us down and said, oh, you have to make art that looks like this. All of a sudden they're not there. And so now the breadth and wealth of the artistic abilities maybe are able to come forth in that way. Or because, again, we as humans just inherently are creative, by nature. And so when we get limited in certain ways, maybe we become more creative in others, right? It's like the brain says, this part isn't working, but the energy is going into this part now.
Mm.
So I'm not sure I have the perfect explanation for that one either, but I would guess that there are many ways of thinking about that.
That certainly happened during COVID.
Yeah, we got many of us got creative, right?
Yeah.
Yeah.
I was
Yeah,
listening
I
to,
see that a lot. Sorry. I also see that a lot at the end. Well, not necessarily a lot, but as people get a diagnosis, they maybe allow or turn to things that they hadn't explored as thoroughly. We took care of a patient who was long term with us. He was an artist, he was a photographer, and he came on thinking that he had maybe months to live. And lots of you have heard this story, but he opened up realms inside himself on many, many levels as a result of having, a terminal diagnosis, and lived for another 5 years, produced a whole different body of work in black and white photography that he hadn't really done before, found a religious home that he hadn't ever had before, many, many things that just opened up for him in that time. And while Alzheimer's, of course, is very different, because you think, well, the brain is less capable of actively exploring things. Nonetheless, I wonder if maybe there's something to that too.
actually, I have a question because I was listening to a podcast today that was talking about split brain experiments and things. And what you just said made me think about the fact that, could it be dependent upon where the plaques develop in the first place? Like if they start developing in one area of the brain, uh, could it be possible that another area of the brain would excel somehow to compensate?
Certainly, we know a lot about. I am so sorry. Isn't that amazing that it didn't happen before? Certainly, we know that the brain has a lot of neuroplasticity, right? In other words, it can create pathways around problems. And so yeah, it makes good sense to me that if you think about, especially early on, if there's damage in certain areas, that certain aspects will, require the brain to work around, then it might, again, sort of open up other pathways. And if we think about, if we're only using 10% of our brain at any given time, right? And now we take out certain pieces of that, but we still have access to another 90%. Why not? Why not think about the possibilities of where all we could go with that much more brain power in there?
Yeah, that's really amazing. I mean, the amount that we're consciously aware of that our brain is doing is so small.
Yeah, right.
So yeah, I mean, when people have experiences like that, I mean, it's a silver lining to look at for sure in those types of situations. It looks like,
Left brain, right brain dominance theory. Yeah.
mhm. Well, I
Um,
think that,
yeah, and stepping out of the rat race, that's and stereotypical living. And yeah, COVID times really took us into a different place, didn't it?
there's a question. What do you think about Musk's? I don't know who that is. Chipping ideas to heighten brain function. I'm very leery, but I am leery. But what is medicine? I'm not sure.
Elon
Elon
Musk.
Elon Musk. Yeah.
Yeah, but I do not know what his chipping ideas are, I'm sorry to say. Huh, I have to look that up. Just don't know the answer
We're
to
not
that.
cool enough to know those things. Sorry.
Exactly. Yeah. Guess I'm not keeping up on what Elon Musk is up to. Sorry about that. Oh, you read in the New York Times yesterday. Well, you're definitely ahead of me. You can share that with us. That'd be great if it's something of interest.
Well, this was great. Thank you so much, Dr. Tron.